All right, thanks for that introduction, Dr. Bilani. My name is Govind. I'll be presenting the case for not delaying care for patients who have continued their GLP-1 receptor agonist perioperatively. I have no financial disclosures relevant to this presentation. So as you all know, over the past year and a half, about 14 major anesthesiology, endocrinology, and gastroenterology societies have issued statements on the perioperative management of GLP-1s. Most statement authors agree that overall there is a lack of high quality data to inform the safety of these medications in surgical patients, and that the recommendations issued by societies have been conflicting and informed by preliminary retrospective studies and case reports. The recommendations are wide-ranging, from the Institute for Safe Medication Practices and the Canadian Anesthesiology Society recommending that GLP-1s be held for 3 or more half-lives and that surgery should be canceled if these medications are not withheld, to other organizations suggesting that GLP-1s may be continued even through the day of surgery. The authors of the Society for Perioperative Assessment and Quality Improvement consensus statement acknowledged that they had identified no studies investigating the safety profile in GLP-1s in patients undergoing GI procedures, saying that its continued use through the perioperative period for other surgeries may be acceptable. I will say it's worth mentioning that in neither the 2017 ASA practice guidelines on perioperative fasting nor the February 2023 update were GLP-1s included as a consideration for preoperative fasting or NPO status. And this is in spite of the fact that GLP-1 agonists have been around for quite some time. The first one was approved in 2005, exenatide, and injectable semaglutide was approved by the FDA in 2017. In response to growing concern over reports of aspiration-related events, along with the increasing popularity of these drugs, last year in June, the ASA Task Force on Preoperative Fasting issued a consensus-based guidance suggesting that patients taking weekly dosed GLP-1s hold these medications for 1 week prior to an elective procedure. The task force also recommended evaluation of patients on GLP-1s for GI symptoms such as bloating, vomiting, or abdominal pain prior to proceeding with these elective procedures, and in the absence of any concerning symptoms to go ahead and proceed with full stomach precautions after discussing the risks of aspiration with the patient and proceduralist. So as many of you in this room may have personally witnessed, this document was widely misquoted as a guideline and not the preliminary guidance that it was intended to be. So anesthesiology practices around the country enacted rules and policies mirroring this guidance, resulting in case cancellations, confusion as to how to implement pre-procedural medication discontinuation, and debate over the optimal anesthetic technique. So to give you some context about my own experience as a quality and patient safety director at St. Louis University dealing with this issue, I thought I'd share a little bit about my hospital and healthcare system. I work at a 356-bed level 1 trauma and transplant academic medical center that serves as the flagship tertiary care center for 25 SSN health hospitals spread across Wisconsin, Illinois, Missouri, and Oklahoma. Anesthetic care at these facilities is largely provided by contracted private practice companies, anesthesia groups, with the exception of our own hospital where the anesthesia group is employed by the university hospital. Several months after the guidance was released and disseminated, we convened a multidisciplinary meeting of pharmacists, anesthesiologists, hospital leaders across all 25 hospitals, and to discuss whether we should implement any changes in our practice for patients presenting for elective surgery who are currently on GLP-1s. We began with an evaluation of our current practice following the guidance release and outcomes following surgery for these patients by analyzing our event reporting systems and mining our electronic database for perioperative aspiration events. And what became immediately apparent after polling all these anesthesia practices was the large variation in practices that had been adopted. Most had enacted the ASA guidance and cited concern over medical legal liability for not being compliant with national guidelines. Some practice leaders stuck to holding GLP-1s for just a week, while others stated that the medication should be discontinued for maybe even a month. And other groups reported maybe not withholding GLP-1 medications at all. Regardless of duration of discontinuation, GLP-1 patients scheduled for cases typically requiring moderate or deep sedation were now increasingly being intubated following a rapid sequence induction. And Among upper endoscopy patients, attempts at pre-procedural diet modifications were also being made to help reduce the likelihood of failed endoscopy studies and potentially aspiration. Assessment of aspiration risk usually hinged on patient symptomatology, but some practices reported the routine use of gastric ultrasound. And finally, some centers that enacted GLP-1 discontinuation prior to surgery and cited challenges with perioperative glucose control, including case cancellations for patients who had presented with severe hyperglycemia. And some of these patients, their only diabetes drug was a GLP-1. Practices with no preoperative assessment clinic depended on surgeons and proceduralists to discontinue medications, while those with preoperative clinics had to adopt brand new protocols and see patients well in advance of their surgery in order to intervene, which certainly was not possible always. So I think we can all agree that, that this is a fairly complicated issue. But over the next 15 minutes, I intend to make the case that not only should surgery not be delayed for patients continuing GLP-1s, but that GLP-1s should be continued throughout the perioperative period. We will discuss limitations to the ASA guidance recommending 1 week of discontinuation prior to surgery, some evidence suggesting longer duration of GLP-1 receptor agonist therapy may not confer a higher risk of gastric emptying delay, and population-based and large outcomes studies looking specifically at pulmonary complications in GLP-1 patients undergoing surgery. We'll also touch on potential adverse effects from abrupt discontinuation of GLP-1s, the utility of gastric ultrasound, and the consequences of elective surgery cancellation for perioperative GLP-1 continuation. So by now, over a dozen peer-reviewed studies and meta-analyses of these studies have demonstrated and reported a significantly increased risk of residual gastric contents in patients taking GLP-1s. A lot of these studies were done in patients undergoing upper endoscopy after following standard NPO protocols prior to this procedure. And this is a great procedure to study because during this procedure, you can clearly visualize with an endoscope the contents of the abdomen, and it makes it kind of the ideal procedure to perform these studies. But the key question that remains is whether the higher rate of residual gastric contents translates to our true outcome of interest, which is aspiration risk or pulmonary complications. So regardless of whether a patient has risk factors for delayed gastric emptying, the presence of residual gastric contents is actually quite common during upper endoscopy. It's also not pathognomonic for delayed gastric emptying or gastroparesis. This was actually shown in a study of over 55,000 patients undergoing EGDs at Mayo Clinic, where 3% of patients were found to have residual gastric contents. And when they looked at whether residual gastric contents predicted the presence of delayed gastric emptying or gastroparesis in a subset of patients that also had undergone gastric emptying scintigraphy studies, which is our gold standard, they found that the finding of residual gastric contents only had a positive predictive value of 55% for the diagnosis of delayed gastric emptying. While GLP-1 receptor agonist prescription is associated with a multiple-fold increase in the risk of residual gastric contents, holding it for a week may not confer any risk reduction. In the Silvera study that's now widely cited, patients with the presence or absence of residual gastric contents in the GLP-1 group had stopped semaglutide approximately 10 days prior. This kind of calls into question whether holding GLP-1s with long half-lives for just a week would even be sufficient, especially considering that their half-life can be as long as 7 days. Interestingly, instead of medication discontinuation, diet modification prior to surgery may be a more pragmatic approach to risk reduction. In this recent study of 300 patients taking GLP-1s for diabetes, diet modification to clear liquids for 24 hours prior to their procedure, which was EGD, was found to significantly reduce the risk of residual gastric contents. The clear liquid diet group had a 1.5% risk of residual gastric contents compared to 10% of those on a regular diet prior to the procedure. A controversial question that where there's limited evidence is whether the duration of GLP-1 therapy impacts gastric emptying delay and whether the studies published have any significant clinical correlation. So several studies suggest that GLP-1 induced delay in gastric emptying may be subject to rapid tachyphylaxis. In one study, healthy volunteers were administered an infusion of GLP-1 over 9 hours. And gastric emptying deceleration did not occur as much after the second meal as it did the first, and was associated with only initial reductions in pancreatic polypeptide levels, which were used as a marker of vagal activation. A second study looked at tachyphylaxis to the effect of intermittent versus continuous infusions of GLP-1 on gastric emptying and its effects on postprandial glycemia. This study actually used scintigraphic measurements of gastric contents and demonstrated that prolonged GLP-1 infusion was associated with less gastric retention than intermittent or acute dosing. In this other study, obese patients were randomized to weekly and dose-escalated semaglutide over 20 weeks versus placebo. The group that received once-weekly high-dose semaglutide in obese patients resulted in no evidence of delayed gastric emptying after 20 weeks of therapy, and in this study they used paracetamol absorption as an indirect measure of gastric emptying. This finding actually supported previous work published in The Lancet over 16 years ago. This looked at a weekly versus BID dosing of exenatide, where rates of gastric emptying at 14 weeks were found to be no different from baseline in patients taking long-acting exenatide. So I will say that several limitations of these studies prevent us from widely adopting the tachyphylaxis theory of prolonged duration of GLP-1 therapy seemingly being protective against gastric emptying delay. These infusion studies describe tachyphylaxis within hours of starting therapy, but clinically, tachyphylaxis-like findings are not really reported until 8 to 12 weeks. Additionally, the dosing and medication types are not really generalizable. But this does bring me to my next point, that current outcome studies do not support the idea that GLP-1 prescription is associated with an increase in aspiration events or complications. In a very recent large database study of 24,000 diabetic patients who were medically managed and underwent emergency surgery, patients prescribed GLP-1s were no more likely to have aspiration pneumonitis, postoperative respiratory failure, or admission to the ICU in the first 7 days following surgery. In a separate study of 82,000 patients, those who had been recently prescribed a GLP-1 were no more likely to have pulmonary complications than those who had been prescribed GLP-1 at some point in the previous year or never at all. This study was actually really interesting because it was one of the first to consider the duration of therapy as a risk factor. Now, large randomized control trials are demonstrating that GLP-1s may provide benefits that go far beyond diabetes and obesity management. They may decrease risk of stroke, major adverse cardiac events, progression of chronic kidney disease, and improve hypertension. The beneficial effects of GLP-1s on cardiovascular outcomes are most likely explained by a combination of metabolic, vascular, antithrombotic, and anti-inflammatory effects. What we are beginning to learn about are the potential adverse cardiometabolic effects of stopping GLP-1 therapy. In this extension of the STEP 1 trial with 2,000 patients, researchers found that semaglutide discontinuation resulted in significant short-term increases in blood pressure and hemoglobin A1C. The proportion of patients who were pre-diabetic actually increased 9-fold after semaglutide discontinuation in both patients who were not diabetic at baseline and those who were pre-diabetic. So you might be saying, well, this data is mostly looking at weeks to months after patients discontinue GLP-1s, which is beyond the window we would normally be holding these drugs preoperatively. So I guess the real question is there any evidence to suggest that holding GLP-1 receptor agonists preoperatively can acutely worsen cardiovascular outcomes in surgical patients? Well, not directly, but I ask you to consider the already marginally controlled hypertensive or diabetic patient presenting for surgery. Many publications highlight the sequelae of hyperglycemia, both as a marker of surgical stress and as an independent factor associated with adverse surgical outcomes such as surgical site infections and systemic inflammatory responses. And nowadays, when patients are increasingly being placed on preoperative carbohydrate loading, up to 2 hours right before surgery with ERAS protocols and asked to withhold their diabetes medication, perioperative glycemic control may become exceedingly challenging. Next, I wanted to highlight the utility of gastric ultrasound when evaluating patients at risk for gastric emptying delay. Gastric ultrasound has been well described for many years and is relatively easy to perform. The probe is placed in the sagittal plane and subxiphoid, and gastric volumes are approximated by first measuring the cross-sectional area of the gastric antrum, as shown here in these slides. And these are a few more images in the equation on how to approximate gastric volumes. And A stands for antrum, P is pancreas, and L is liver. And qualitatively, you can distinguish solid food from liquid food quite easily, as seen here. And solid food has a kind of speckled, heterogeneous appearance, and liquid is more homogeneous appearing on the right. Here's some images of my own gastric antrum 2 hours after the consumption of a small meal. And the second photo is after I had a full can of Diet Coke, and you can see a nice pocket of air preventing deeper ultrasound penetration, which I generated by jumping up and down in the PACU bay where I was imaging myself. And in the context of this pro-con discussion, I bring up gastric ultrasound to illustrate a few limitations. The original gastric ultrasound and volume validation studies largely included skinny patients with much lower BMIs. And when studying its ability to measure volumes in morbidly obese patients, it was found that these gastric volumes that were estimated and measured with ultrasound, while they correlated with suction contents, the gastric ultrasound generally overestimates gastric volume in morbidly obese patients. This is due to the contribution of the comparatively larger gastric wall in obese patients to the measured antral cross-sectional area. Finally, I will mention that operator inexperience can also contribute to errors in both positive and negative findings, and that performing much more than just the 30 or 40 exams that may be cited to achieve competence may be necessary to be able to really make actionable decisions that affect your anesthetic management. I would argue that gastric ultrasound findings largely should inform how and not just if we proceed. Outside of the endoscopy suite, most practitioners will proceed with a rapid sequence induction regardless of whether gastric ultrasound was performed. But if one was performed, it should really take into account that residual gastric volumes can also be up to 1.5 cc's per kilo of total body weight in appropriately fasted individuals. If gastric ultrasound reveals the presence of large volume gastric residue or solid particulate matter, that may present an opportunity to halt proceeding to surgery and prompt a risk-benefit discussion related to aspiration risk with the patient and procedural team. And in these situations, most endoscopists would also argue they're probably not going to get a very adequate EGD study if there's solid food in the stomach. For elective surgeries, most patients would probably balk at the idea of preoperative awake NG tube placement and an elective awake fiber optic intubation for airway protection. So let's say before canceling a case or proceeding with an RSI, there are opportunities when we see residual gastric contents to go ahead and actually administer gastric motility agents and reevaluate with gastric ultrasound that can be taken advantage of. My last point is that I think we can all agree that by no means is surgical case cancellation trivial. Many of our programs have worked really hard and gone to great lengths to reduce day of surgery case cancellation, to optimize OR utilization, help facilitate surgical care delivery, which becomes even more important in resource-limited contexts where we are maybe providing care for underprivileged patients with very poor access to care. I ask you, though, to consider the finding of this fairly recent study, which I thought was really striking to the point that I reached out to the author to probe a little bit further. What he found was actually similar to what we saw at our own tertiary care academic center, where that almost a third of patients presenting for surgery but canceled due to medical or anesthesia reasons, they may never get rescheduled, and that those who did often experience significant delays in care. So I think that kind of shines light on some of the human cost of canceling surgery, the time patients take off of work, the family members who've taken time to bring the patients and support them through recovery, and the resources it may have taken even just to transport those patients there that morning. So in conclusion, will reiterate that the ASA guidance is not they're not guidelines, and that more robust evidence on diet modification and therapy duration will help guide future management of patients taking GLP-1s. Although the association between residual gastric contents and GLP-1 therapy is becoming really well established, GLP-1 use has not been linked to an increase in pulmonary complications or aspiration events. Abruptly discontinuing GLP-1 receptor agonists may not decrease residual gastric content risk, while it may still introduce cardiometabolic risks such as surgical site infections from poor glycemic control in place of far more rare aspiration-related complications. Gastric ultrasound may be a useful tool in the anesthesiologist's armamentarium and should help inform us how to proceed safely. And again, elective surgeries, case cancellation is not trivial, may contribute to patient harm that goes unrecognized in the moment of cancellation. Thank you.
Thank you,